The aim of this video is to describe the main features and strengths and weaknesses of case control study design. So a case control study begins with the identification of a group of cases and the identification of a group of controls. At this stage, the exposure status is unknown. Past or present exposure levels are then obtained, and these exposure levels are compared between groups. If the exposure is more or less common in the cases versus the controls, then it might be a causal factor. So here's an example of a very famous case control study that looked at smoking and lung cancer and was published in 1950 by Richard Doll and Austin Bradford Hill. Cases were recruited from hospital patients who had lung cancer, and controls were taken from another group of hospital patients who had diseases other than cancer. Exposure histories with respect to smoking and many other factors were then compared between the groups, and they found that past smoking was much more common in the lung cancer cases, and subsequently concluded that there was an association. So the main advantages to this particular design were its speed and cost. By sampling on people who already had the disease, there was no need for a long follow-up. It was also efficient. They would have had to study a large population at risk to get the same number of cases that they studied in this particular study. However, there were several limitations. The study design did not allow them to measure the absolute risk of lung cancer from smoking, and they also didn't know whether other diseases might be associated with smoking. In a case control study, you only study one outcome. And lastly, there are several other types of biases that particularly affect case control studies, such as selection and recall bias. So the findings were investigated further with a prospective cohort study of 34,000 doctors. Information on smoking and other behaviours was extracted by questionnaire, and members were then followed up periodically for mortality. And the study eventually closed some 50 years later in 2001. But within the space of 4 years or so, and with very limited data on mortality, the investigators were able to show some evidence of a graded association between dose of smoking and lung cancer mortality. Now, there are distinct advantages and limitations to case control and cohort studies, so the replication of results in the two different study designs provide more evidence for a link between smoking and lung cancer in this example. Let's talk about a few principles of case control design, as they're probably one of the most acceptable designs to bias, and so the most difficult to do well. One of the first steps is to define the cases. In the example discussed, it was something like all cases of lung cancer under 75 years of age that presented to London hospitals between 1948 and 1949. So the source population for these cases would obviously be hospitals. In some studies, you may be able to use population-based cases. The definition of cases is particularly important because the key principle for selecting controls so that selection biases are minimised is that they should represent the population from which the cases came. And controls may come from several sources. For example, they may be hospital-based, based on general practice registers or electoral registers. So these latter two can be described as community-based controls. A potential source of selection bias with using hospital controls occurs when the control group is selected in a way that biases it with respect to the exposure of interest. For example, if the exposure of interest was alcohol, it wouldn't be sensible to source controls from patients with alcohol-related conditions, for example, ulcers, liver disease or heart problems. This would underestimate the association with the exposure. So the use of hospital controls thus requires knowledge of the etiology of the other conditions, which might be unknown. And controls can be matched. Matching is a procedure where one or more controls are selected for each case on the basis of similarity of certain characteristics. Typically used matching criteria are age and sex, but others might be socioeconomic circumstances or place of residence. So matching is a way of controlling for confounding because it balances the groups by the factors that were matched on. Now, case control studies are typically used to investigate rare outcomes that would be difficult to capture in a cohort study. Typically then, it's much easier to recruit extra controls than it is to recruit extra cases. And we can increase the power of a study by increasing the ratio of controls to cases. A ratio of 4:1 will improve the power of a study appreciably over a ratio of 3:1. However, any higher ratios add little extra benefit in terms of power. And the exposure can be measured in many different ways, for example questionnaire, in person or by telephone, from medical, occupational or other records or biological samples for instance. The important aspect is that the information gathered on the exposure is unbiased and not influenced by whether an individual is a case or a control. In terms of analysis, we can't calculate the risk or instance of disease because we don't know the number at risk. The sample for a case control study begins with people with a disease, not individuals at risk of the disease as in a cohort study. However, we can measure associations using odds ratios. Odds ratios are very similar to the risk ratio when the disease or outcome is rare, so you sometimes hear the terms being used interchangeably when this is the case. So the nice thing about odds ratios in terms of using them for case control studies is their symmetry. So if you remember, in a case control study we compare the distribution of the exposure in the cases versus the distribution of the exposure in the controls. So if we had an odds ratio of 4, we would say that the odds of being exposed in the cases was 4 times that of the odds of being exposed in the controls. Now this seems the wrong way round. What we really want to know is what are the odds of having the outcome if you're exposed versus the odds of having the outcome if you're not exposed, not the odds of exposure in the cases versus the controls. And it just so happens that these two forms of presentation are exactly the same, and you can see that in the calculations done in this table. So we can use the odds ratio as a measure of effect of the exposure in a case control study. And if the outcome's fairly rare, less than 5 or 10%, then the odds ratio is approximately the same as the risk ratio, which is nice because most people, except gamblers perhaps, find risk much easier to interpret than odds. So let's look at the common biases that we've discussed so far. So first, selection bias is a big potential weakness in this design. We've said that it's important that cases and controls are selected independently of their exposure status, and we gave the example where the interest was in alcohol as the exposure. And we can try to minimise this type of selection bias by holding in mind this idea of sampling controls from the population that generated the cases. Loss to follow-up bias. Well, that's irrelevant to case control studies because we start the study by selecting participants with and without the outcome. There is no follow-up. And in terms of measurement bias, well, there's always the potential for random error in the measurement of the exposure. And if that's non-differential or independent of whether an individual is a case or not, that will bias the results towards the null. So we always have to be aware of this sort of error. However, if the error depends on whether an individual is a case or not, so-called differential measurement error, then it could bias results in either direction. And in the setting of a case control study, we call this recall bias. So this may occur for many reasons. For instance, a case may be more likely to report exposure or remember an exposure because they take the question more seriously and might subconsciously be attributing past exposures to their disease. And there's also interviewer bias. This would occur if the researcher is aware of the study hypothesis and makes more effort to ascertain the exposure among the cases. This is analogous to detection bias in a randomized controlled trial, where the assessor may detect the outcome differently depending on whether the participant is in the treatment group or not. So confounding, again, is observational studies, so something to consider. And reverse causality. This is of course always a bias to consider for case control studies because information on the exposure is gathered retrospectively after the outcome has occurred. So for example, if the interest was in a dietary component, then it's possible that a period of illness or disease would cause a change to dietary behaviour rather than the dietary behaviour causing the illness or disease. And lastly, generalisability, which will depend to a certain extent on the case selection. So here, a question is, can the results be generalised to other populations? So to conclude and summarise, here's a list of the strengths and weaknesses of case control studies that we've discussed.